Good evening, everybody. Welcome to CRS Virtual Education. Tonight, I am very happy to introduce Dr. Schlechter, who's been kind enough to join us. He is a medical oncologist specializing in GI cancers, including colorectal cancer, anal cancer, pancreatic, and neuroendocrine cancers. He's a former intern and resident and chief and fellow as well at the BI, as well as a member of the faculty at Harvard Medical School. In the past, he was director of inpatient hematology at BI as well as the assistant program director of the IM residency. Currently, he is working at Dana-Farber, where he focuses on providing excellent patient care and trying to advance treatment of GI cancer patients. And so we're very grateful to have him here today to talk about chemotherapy in colorectal cancer. And with that, we'll say, take it away, Dr. Schlechter. And as always, if anybody has any questions, please send those through Surgeon, and we'll go ahead and curate those for Dr. Schlechter at the end.
Excellent. Thanks for having me. No, this is a great topic, and I think colorectal cancer is having a bit of a moment, so I'm glad we're talking about this today. In terms of disclosures, hold on, we are not advancing. There we go. So I have served on the advisory board for Deaconess and Janssen in consulting roles. So we're going to talk a little bit about the biology of colorectal cancer insofar as I think it's relevant for chemotherapy questions and their impact on surgical decision-making. We'll talk about resectable and advanced disease and the value of some of the mutations that are relevant, including KRAS, BRAF, and HER2, and then some of the emerging data on immune therapy, both in mismatch repair proficient and deficient cancers, and relevant considerations there. First, in terms of biology, we divide colorectal cancer into three main subgroups. I think it's worth just briefly mentioning them because it does inform some of the treatment decisions we have. There's a traditional subtype of colorectal cancer called chromosomal instability phenotype. That's actually a misnomer in many ways. That is what we think of as colorectal cancer. It's actually not that unstable. There's very few mutations. These are relatively genomically stable cancers. When you say colorectal cancer, this is really what you're thinking about. And it's just genetically, there's some large-scale genomic differences between normal tissue and the cancer. So I think a better term for this is allelic imbalance. The flip side, the opposite side of that, is the mismatch repair deficient cancers, the microsatellite unstable cancer. Those are the Lynch syndrome cancers with high mutation burden, or the sporadic mismatch repair deficient cancers. What this looks like on a PCR gel, we have two alleles here. One is a maternal allele, one is a paternal allele. The blood will be sort of wild type and normal. We have two very, very similar alleles. In the cancerous one listed as loss of heterozygosity or allelic imbalance, you can see there's this mismatch where there's either amplification of one or deletion of another, but there's not necessarily a neoantigen. There's no new targets for, say, immune therapy, whereas in the mismatch repair deficient cancers, what you see is a neoantigen that results from DNA repair defects that are actually quite substantial and have an impact on treatments. This is why I think this name is a little bit inaccurate. And the final group that we think about are the CIMP patients. That's a group of patients where their cancer has epigenetic changes that silence certain genes or may promote certain genes. And so their behavior may be a little bit more variable than the more common allelic imbalance subtypes, the CIN subtype. In terms of how we think about the biology of these cancers in their behavior as opposed to genomic findings, there's the sort of the wild type cancer. These are cancers where they don't have a KRAS mutation, for example. Obviously, they're still cancerous, but they are driven by more normal pathways. The most common mutations we see are in the MAP kinase pathway. This is BRAF and KRAS. Normally, MAP kinase is sort of the engine that drives surface receptors and responds to the environment, the hormonal environment around the cancers. And these mutations result in an internally motivated cancer. They're more likely to spread. They're going to be independent of growth signals like EGFR. And then we have some rare subtypes like HER2 amplification, where we upregulate a MAP kinase receptor, and HER2 very famous from breast cancer, but also present in colorectal cancer. And then again, the microsatellite unstable cancers, just like in the genetic phenotypes, this biological behavior is sort of borne out. In a cartoon fashion, what we see here is the EGFR pathway, the MAP kinase pathway. You have RAS, which is a critical member of that pathway. There are various RASs, not just KRASs, NRAS and HRAS. KRAS is most commonly mutated in colorectal cancer, BRAF, and then we have MEK and ERK and other contributors. Fundamentally, if we think about the frequency of these subtypes and how they inform our decisions, the RAS-RAF wild types are somewhere around half of patients, but they're less common in left-sided cancers. The KRAS mutated is a little bit less than half, and everything else is around 3%. So when in doubt, if you're asked how common something is in colorectal cancer, if it's not KRAS, it's 3%. BRAF is 3%. HER2 is 3%. Mismatch repair deficient is 3%. We have a number of other very rare mutations which may eventually impact treatments, such as PI3 kinase mutations, POLE hypermutated cancers, in particular in young adults. But those are really, really uncommon and probably don't have much of an impact on therapy now. The main principles for curative intent therapy in colorectal cancer, we know them, but I think it's always important to reemphasize them. Staging should be performed on every patient with adenocarcinoma of the colon. That's a CT of the whole torso, chest, abdomen, and pelvis. And it's really helpful to have a preoperative CEA because postoperative CEA trajectory can be informative about prognosis. Surgical resection, as you all know, a high quality resection would include negative margins in 12 resected lymph nodes. And it's absolutely critical that all patients undergo mismatch repair testing, either immunohistochemical testing, it's hard to say somehow tonight, either PCR, NGS, one of these tests. I really think these should be performed on the colonoscopy specimens at diagnosis rather than on a surgical resection when possible, because if you find a Lynch syndrome-associated cancer, you may actually make different decisions about your surgical management. The patient may choose a total colectomy rather than a partial colectomy, even though surveillance is improved. Some patients may choose that, and we should know that. And you also want to think about what your surveillance options are. So fundamentally, the main resectable cancers are stage 2 and stage 3 colorectal cancer. Stage 1 is a surgical disease alone. You don't need a medical oncologist. Stage 2 disease are those that have invasion through the muscularis without nodal involvement, and stage 3 cancers have nodal involvement. There's a couple of nuances that speak to prognosis and decisions around adjuvant therapy. First of all, T4 cancers do poorly, actually do quite poorly. Tumor budding is an emerging marker, as we all know, but tumor budding in stage 2 cancer is prognostic. And then, of course, mismatch repair deficiency is critical. For stage 3 cancers, we recently added the designation for N1C. These are mesenteric nodules. Before 2018, they were not included in the staging of colorectal cancer. So as a result, a lot of the retrospective data and even prospective data we have doesn't really include these nodules, these mesenteric nodules. These things are a problem. Patients with N1C nodules with tumor deposits do poorly. And it's really important that we account for them when we think about the staging of cancer. So even though they're kind of strangely incorporated into the staging system, an N1C nodule really may be worse than an N2 cancer, even depending on the risk profile. And so these are really important not to ignore. It's really important to look for them in your surgical reports, and we as oncologists need to look for them as well. ctDNA is the new test on the block. This is a really, really powerful tool to detect evidence of minimal residual disease. It's certainly prognostic. I don't think there's any question that a positive ctDNA predicts a poor outcome. That doesn't mean that we can alter that outcome. We actually don't know that yet. And I would not be entirely reassured by a negative ctDNA. Certainly, negative ctDNA has a good prognosis, but that's not justification to de-escalate care yet. And so these are investigational. These are undergoing clinical trial. Many centers have adopted them. I think that they should be adopted with caution. The main clinical trials that dictate adjuvant therapy, I think, are important today. So let's talk about Mosaic. Mosaic was published in the New England Journal in 2004. This is a practice-changing trial. This is a prospective randomized trial of over 2,000 adults with stage 2 and stage 3 colon cancer that had been resected. Rectal cancer was not included in this trial. And patients were randomized to receive 6 months of either 5-FU leucovorin, the so-called Degermont regimen, or FOLFOX, which is that combination plus oxaliplatin. The primary endpoint was disease-free survival, and we have long-term overall survival data on this as well. What we see here is the Kaplan-Meier curve of survival from Mosaic, and it's very clear that those patients who received the combination of 5-FU with oxaliplatin in stage 3 disease had a substantial improvement in overall survival and disease-free survival. There was a very moderate but non-statistically significant improvement in stage 2 disease in this population. Thinking about toxicity, and I think this is an important question because we all think about chemotherapy as potentially toxic. I would think of every chemotherapy as uniquely toxic, but toxicity is not universal among them. For example, it is exceptionally uncommon to see alopecia with 5-FU-based regimens. The most common side effect of oxaliplatin and FOLFOX is cold sensitivity, a weird sensitivity to cold that can be quite striking for some patients. If they touch something cold or eat something cold for several days after being dosed, they can feel a really odd sensation. Rarely people like it. I would say in the past gosh, over many years, 10, 15 years, I've had 3 patients who notably enjoyed the toxicity of oxaliplatin, but pretty much everyone else finds it to be an unpleasant sensation. There's a subset of individuals who can get permanent numbness and tingling from oxaliplatin, and that is an important consideration when the benefits are important but moderate. Neutropenia is the other thing we think about. Febrile neutropenia obviously is quite dangerous for patients. At the time of this publication in 2004, you could see that a substantial number of patients had some neutropenia, but significant neutropenia was pretty limited. In the modern era, we have agents that can address neutropenia like pegfilgrastim and filgrastim. Neutropenia actually is much less of a common problem with FOLFOX. So it's important to know that it can happen, but severe reaction, severe nausea is exceptionally uncommon, and cold sensitivity is a dominant side effect. 5-FU without oxaliplatin is generally very well tolerated. It's uncommon to see significant toxicity outside of patients with DPD deficiency, and all patients with colorectal cancer where chemotherapy is a consideration should undergo DPD testing, because that can be a dangerous or even lethal toxicity. The summary of Mosaic is this. For stage 2 cancers, pretty much FOLFOX versus 5-FU and leucovorin had similar outcomes, and so there's limited data from this trial to support the use of FOLFOX. For stage 3 cancers, FOLFOX should be the standard of care in the adjuvant setting, and mismatch repair deficient patients in analysis from this trial only derived benefit from FOLFOX and not from the antimetabolite combination 5-FU and leucovorin. This makes sense when you think about the mechanism of oncogenesis as being a DNA repair defect. So a DNA repair damaging agent like oxaliplatin had a benefit, and an antimetabolite like 5-FU, which really doesn't affect DNA repair, had no benefit. And so adjuvant 5-FU is not needed for patients with low-risk stage 2 cancer from a mismatch repair deficient disease. And if adjuvant therapy is to be offered, it should always be given with oxaliplatin. And overall, this was a practice-changing trial. There was a lot of concern from Mosaic thinking about neurotoxicity and the long-term outcomes for patients. And this isn't an important consideration when the benefits are important but moderate. And so a collaboration was launched called IDEA. And this is a really, really cool study. So essentially, multiple clinical trials were all grouped together, all with the same design. In all cases, there would be either FOLFOX or CAPOX, which is an oral regimen with similar efficacy. Everyone would receive that. And there would always be a study drug, FOLFOX plus or minus this, CAPOX plus or minus that. And in addition, there would be a second randomization, a 2x2 design of 3 months versus 6 months of therapy. And so all of these trials had nearly identical designs, and they all sought to address whether we could do better than FOLFOX or CAPOX and how much chemotherapy is enough. It's a really important trial. 6 prospective randomized clinical trials were performed across the United States, Europe, and Asia, including 3,263 patients with stage 3 colon cancer. Rectal cancer was not included, and mismatch repair deficient cancers were not included. Patients, as we said, were randomized to 3 months versus 6 months and an investigational agent. Every investigational agent failed. There has never been an improvement on FOLFOX and CAPOX in the adjuvant therapy of colorectal cancer, which is good to know that we've been using a fantastic regimen for 20 years. It's also kind of disappointing that we can't quite do better than that. The primary endpoint was investigator-defined non-inferiority of 3 months versus 6 months, as well as the superiority of the investigational agents, as we said, all of which were completely negative. What we saw was this. In the all-comers population, there's no major difference between 3 months and 6 months of chemotherapy in the adjuvant setting for stage 3 colon cancer. There's some nuance here. There's always some nuance here. So if we dig down deep on who benefits from 6 months of therapy versus 3 months of therapy, we can see that T4 cancers, which have a worse prognosis, they benefit from the 6 months compared to 3 months in the investigator-specified non-inferiority. And the same thing with the N2 T4 combination, high-risk patients do better. The way I think of chemotherapy is this: chemotherapy mitigates risk. And so the higher the risk of recurrent disease, the greater the benefit of chemotherapy. And that's why you see this finding where the lowest risk patients, really more is not better. Less is just enough. And for the highest risk patients, T4 and N2, more chemo is more better, even if the differences are moderate. And we can see these in additional plots. As you can see, there's a statistical benefit. The benefits are moderate, but they are real. When you account for common disease, many thousands of lives are saved by that 3 additional months. There's some emerging data on 3 months of FOLFOX followed by 3 months of 5-FU, for example. And it looks like retrospectively, it's okay to de-escalate, and prospectively is under investigation. So our conclusion from the IDEA collaboration published in the New England Journal in 2018 is that for low-risk stage 3 colorectal cancers, defined as N1 or T1 to 3, not T4, adjuvant capecitabine with oxaliplatin for 4 cycles, which is 3 months of therapy, is non-inferior to 6 months of therapy. For high-risk disease, those with T4 and N2, 6 months of adjuvant therapy is preferred. It's important to know that mesenteric nodules, those N1C nodules we talked about before, those were not included in this analysis. And so their impact was not prospectively studied, and the role of ctDNA was not included. But I would say if you have a patient with N1C nodules, that's such a high-risk features, we think of chemotherapy as a risk mitigation strategy that we should think about 6 months of therapy. ctDNA is more controversial, but it's probably the same, that higher risk disease needs more chemotherapy, but that is not proven in prospective trials. So in summary, adjuvant therapy for colorectal cancer, for T3N0 disease, I think it's worth considering observation versus a fluoropyrimidine alone for 6 months based on the MOSAIC trial. For T4 disease, for higher risk cancers, there's benefit potentially for a combination in 3 months of capecitabine and oxaliplatin is reasonable to consider. For lower stage 3 disease, 3 months of CAPOX should be a reasonable standard outside of a clinical trial trying to study additional interventions. And for higher stage 3 disease, T4 and N2, and keep in mind those other risk factors, 6 months of adjuvant FOLFOX or CAPOX should be considered. And for all patients with stage 2 or stage 3 resected colorectal cancer, they need a colonoscopy a year from diagnosis. They need a CEA every 3 to 6 months for 5 years, and they need a CAT scan every 6 months for 2 years from surgery. And then after that, every year until 5 years from surgery. That'd be the NCCN-based guideline for surveillance. Rectal cancer is sort of a different beast here. So there are many, many different ways to define rectal cancer. Many clinical trials use distance from the anal verge. That's just a way that we can all speak the same language, but that doesn't actually define the rectum. And I think all surgeons know this. For simplicity's sake, we should think of rectal cancers as those cancers of the colon that are at or below the peritoneal reflections or have the potential to involve the mesorectal fascia. What we are addressing in rectal cancer therapy is the mesorectal fascia. As we said, definitions vary. The absence of visceral peritoneum around the rectum is what allows this early penetration of these cancers, and there may also be some biological features that make these cancers more aggressive. It's beyond the scope of this conversation today, but there's a substantial increase in young onset colorectal cancer, heavily weighted towards the left in rectal cancer. And when we think about the consideration of rectal cancers, we also have to think about the considerations in younger patients. So there's many paradigms for rectal cancer therapy, and it's important to know that all of these have very, very similar outcomes. There are some subtle differences between them, but we should not think of any of these as the blockbuster approach. Every one of these is important. So there's the conventional approach to rectal cancer, which we're going to talk about. There's the modern TNT approaches. It's a great acronym that, I don't know, it is what it is. The trials to know are Rapido and Oprah. And we have these intensification and de-intensification trials, produced 23 out of Europe and Prospect out of the United States. So the modern approach to rectal cancer actually is a multi-decade process with the development of the total mesorectal excisions, the LAR and the APR. And then we have a series of observations in clinical trial. There was an observation that local recurrence was common after rectal cancer surgery, that adjuvant radiation improved outcomes. Adjuvant chemoradiation was better than adjuvant radiation. There was an attempt to look at neoadjuvant therapy. That improved outcomes as well. And functional outcomes were better with neoadjuvant therapy than adjuvant therapy. And as we entered the modern era, with clinical trials that looked at neoadjuvant chemoradiotherapy or radiation therapy, surgery, and then the role of adjuvant therapy. We entered the FOLFOX era. Then we had the ADORE study coming out of the UK, published in 2014. So the paradigm from ADORE and the paradigm for modern rectal cancer therapy until the recent time was that for all stage 2 and stage 3 rectal cancers, those are cancers with at least a T3 or with node involvement. The implication of a T3 disease being that the mesorectum is sort of infected by cancer, and the difficulty in assessing disease because MRIs are moderately accurate and CT is just plain inaccurate, and EUS is so user dependent. So any patient with evidence of stage 2 or stage 3 rectal cancer should receive these approaches. And this was a paradigm of chemoradiotherapy with sensitizing capecitabine or 5-FU and 8 to 11 week hold before surgery, surgical management, and then 4 months of adjuvant FOLFOX or CAPOX. And that had an improvement in disease-free and overall survival, which was significant. This was a large phase 2, actually not a phase 3. Also coming out of Europe is the Rapido study. This looked at short course radiotherapy, an extrapolation from the Stockholm trials, compared to long course chemoradiotherapy. Short course is 5 days of radiation, 25 gray total, as opposed to 5.5 weeks of radiation in the long course. These two arms were essentially the same, the ADOR paradigm versus the Rapido paradigm. There are some nuances here. For a period of time, I would say this was a really, really important innovation in the management of rectal cancer. The long-term follow-up data of the Rapido clinical trial showed that overall survival remains similar between chemoradiotherapy, surgery, and adjuvant FOLFOX compared to short-course radiation, FOLFOX, and then surgery. However, there is an increase in local recurrences in patients treated on the study arm here, in particular in patients with node-positive disease. So while this is an important paradigm, I think it has fallen out of favor, in particular in the United States, because of these concerns over nodal recurrence and local recurrences. And that is not an insignificant problem. As we know, the salvage for local recurrence in the pelvis is going to be APR from an LAR or a zenteration. So very morbid surgeries, which we may be able to preserve overall survival. We are not preserving quality of life. One of the other very important observations about rectal cancer was the identification of complete responses. The complete response rate varies between trials, but a subset of individuals who had neoadjuvant chemoradiotherapy would have a pathologic complete response at the time of surgery, and some of them were identified as having a clinical complete response. Patients who had a pathologic complete response had excellent outcomes, as we would expect. Patients with a clinical complete response started to refuse surgery, and there was even prospective investigation of this, to the point that there are patients who were undergoing non-operative management for rectal cancer. And so a clinical trial was pursued, led out of Sloan Kettering, looking at chemoradiotherapy followed by chemotherapy and then surgery versus non-operative management, or the flip side, chemotherapy versus chemoradiotherapy, not comparing this to a standard such as the ADOR trial, but other trials have done this, especially in Germany, but trying to figure out which is best, chemo first or radiation first. And the winner in the Oprah trial was that chemoradiotherapy followed by chemotherapy in terms of local control was superior to chemotherapy first. And so pretty much trial after trial has shown that chemoradiotherapy or radiation therapy first always has the best local control. And this really brought home that point. What we saw with the chemoradiotherapy first approach was that 44% of patients had a clinical complete response or a near complete response and could consider going on to non-operative management. Importantly, the assessment is not done at the end of therapy. So you have your chemoradiotherapy period, you have 4 months of systemic therapy with FOLFOX or CAPOX. Then there's an 8-week pause to allow full onset of benefit of all therapy, and then an assessment. And to assess earlier, it's not known if a patient needs to move on to therapy or not. And we know from anal cancer data that takes 6 months to see full effect of radiation. So it's important that patients undergo this pause. I will say, for patients with a CEA that's concerning or symptoms that are concerning, I think it's very reasonable to pursue earlier imaging right at the end of systemic therapy and consider moving quickly to surgery for patients where a non-operative management is just not going to happen and the delay may affect the outcomes. Importantly, as well, we have to be very careful about what OPRA means. And I think it's occasionally challenging for patients who read the term organ preservation and think of it as a promise, not an opportunity. Organ preservation is opportunistic and occasional, which is to say 44% of patients go on to non-operative management. Of those who go on to non-operative management, half of them will ultimately require surgical management. And so that's a relevant consideration, because when patients go on to surgical management, they're actually less likely to have an LAR than they would have if they'd had surgery earlier. On balance, more patients are preserving their rectum with the OPRA approach, but there's a subset of individuals where there's a cost to that. And so it's just important not to overpromise what OPRA means. Whereas we had the total neoadjuvant therapy approaches, we looked at chemoradiotherapy or radiation therapy followed by chemo. PRODUCE 23 looked at an intensification approach. So if we have shown that FOLFOX is better than 5-FU, there is this modern regimen called FOLFIRINOX, which is an intensified regimen of FOLFOX plus irinotecan. And maybe we could show outcomes that are improved with that. It is important to note that irinotecan in the adjuvant setting in colon cancer, in the postoperative setting, has never been shown to improve overall survival. So this is an overall survival study that's using irinotecan in a new and interesting way, but we have to be very skeptical of irinotecan. So PRODUCE 23 took patients and randomized them to chemoradiotherapy in the conventional approach with capecitabine, mesorectal excision, and then adjuvant FOLFOX. In this case, it was 6 months, so that the chemotherapy would be matched between them, even though the ADOR study looked at 4 months. It's a nuanced difference. especially when you think about ADORE and IDEA, where increasingly 6 months of chemotherapy has fallen out of favor. And it randomized those patients to receive modified FOLFIRINOX, so FOLFOX plus irinotecan, for 3 months, then full dose long course chemoradiotherapy, then a pause, then mesorectal excision, and then 3 additional months of FOLFOX, a perioperative approach. This is not a total neoadjuvant approach. And what we saw was that the intensified chemotherapy improved outcomes in a number of ways. We have to be very careful how we interpret the PRODUCE 23 data. So first of all, and importantly, one of the observations was that patients who had FOLFIRINOX had rapid improvement in symptom burden as compared to those who had chemoradiotherapy. So in the past, we thought about the palliative benefit of radiation. And here we see that intensified chemotherapy can palliate a locally advanced rectal cancer that's very symptomatic. The other challenge here is adjuvant therapy was very incomplete between the 2 arms. So in many ways, PRODUCE 23 looked at FOLFIRINOX, an escalated regimen, followed by chemoradiotherapy, followed by some people got adjuvant therapy, versus chemoradiotherapy and some people got adjuvant therapy. And that's a real imbalance in chemotherapy. Obviously, intention to treat assessments are critically important in clinical trials that may speak to the behavior of the treatments and the outcomes. But in most clinical trials, actually, completion of adjuvant therapy was much higher. And I will say in my practice, it's pretty uncommon that someone didn't complete adjuvant therapy. And so we have to be cautious about the benefit of the modified FOLFIRINOX arm because they were substantially overtreated relative to the control. Nevertheless, there was a benefit in progression-free survival and overall survival, and there was a 7-year follow-up presented at ASCO this past year, which showed that this benefit persists. So I do think that this is an important lesson in intensification. I'm not sure if in all patients it is as good as it seems if we're careful about delivering adjuvant therapy to patients. This is also being looked at in the total neoadjuvant setting. The open and enrolling Janus trial is looking at FOLFIRINOX versus FOLFOX using the OPERA approach of chemoradiotherapy, FOLFIRINOX versus FOLFOX, and then on to non-operative management versus resection as appropriate. This is the PRODUCE 23 approach is a really intense and long treatment. And so that's maximal benefit or an attempt to achieve maximal benefit from maximal therapy. As we've seen with IDEA, actually maximizing benefit doesn't always require increasing the amount of therapy. And so for low-risk individuals, maybe de-intensification is the way to go. And here we have the PROSPECT trial led by Deb Schrag. This is a fantastic study that was done here in the United States. It took patients with the lowest risk of local recurrence in the pelvis who still qualified for neoadjuvant therapy, and patients who were not a candidate for APR, people with higher tumors. So the tumor had to be a patient who was a candidate for an LAR, no threatened CRM, no more than 3 lymph nodes, and they had strict criteria for lymph node involvement. And that's the population. This is a low risk population. And it's really important that we don't jump to conclusions, but whether we can do the same paradigm in high risk disease, because frankly, we don't know. Those patients then went on to receive either conventional chemoradiotherapy, resection, and adjuvant FOLFOX, or FOLFOX for 3 months and an imaging assessment at 3 months. And if they had a greater than 20% reduction in their primary tumor, they would proceed to surgery. And if they had a less than 20% reduction, then they would proceed to chemoradiotherapy, resection, and then adjuvant therapy. It's important to know that 91% of patients had a greater than 20% reduction and then could avoid radiation entirely. And that did improve long-term functional outcomes for these patients. So de-intensification, lower risk stage 3 disease and stage 2 disease could achieve substantial functional benefit from de-intensification without threatening overall survival. So this is a lesson in de-intensification, the opposite lesson, obviously, of PRODUCE, where intensification was the goal. But we should not jump to conclusions about de-intensification with chemotherapy approaches. So if a patient has a really locally advanced disease and we're using the PROSPECT approach or the PRODUCE approach, you can't then skip radiation. I think you have to stick to the pathway that you're on if you had a reason for choosing that. So we have to be careful about those conclusions. So in terms of summarizing modern approaches to rectal cancer and the implications of chemotherapy, for low-risk tumors, let's say an N1 cancer that's higher up, where functional outcomes tend to be good, I think it's very reasonable to consider a chemotherapy-only approach of FOLFOX, assessment, radiation only if needed, and then adjuvant FOLFOX. For tumors that are lower down that threaten the sphincters or non-operative management is a consideration, OPERA is the way to go, right? Chemoradiotherapy followed by chemotherapy, This gives us the maximum time to receive absolute benefit, and we can attempt non-operative management. And if available, patients should be enrolled in the Janus trial. This really should be where we're putting patients whenever humanly possible. This is that FOLFIRINOX versus FOLFOX randomized trial, alliance trial. For patients with very symptomatic cancer, very big and unpleasant tumors, it seems pretty clear from PRODUCE 23 that intensified chemotherapy is a benefit. I don't think that the data from PRODUCE 23 is quite there to say that this should be the standard in all cases, because again, we saw in Prospect there was no benefit to adding additional metrics. And so for higher risk cancers, a lot of those very symptomatic cancers, I think this is a reasonable standard. That's not what was studied prospectively, so we should be cautious, but I think it's a reasonable approach. And unfortunately, Rapido, which I was enthusiastic about for a bit, it's a little hard to know what to do with that. But when there is a time consideration for a patient, then I think it's a reasonable approach. We have to be really, really diligent at local recurrences in the pelvis. Ultimately, given the complexity of rectal cancer management, I think multidisciplinary care is absolutely critical. There are nuances around surgical care, radiation care, and chemotherapy care that are important. And I think within the multidisciplinary paradigms, we have to be respectful of surgeons, because ultimately the people who cure colorectal cancer are the surgeons. And so we, as the chemotherapists and the radiation therapists, have to keep in mind what you're facing in the operating room is actually really important. And that's a voice that can't be ignored. So medical oncology and radiation oncology shouldn't be the only deciding factors. And I'm saying this as an oncologist. All right, let's talk about systemic therapy for advanced disease. And we can talk about some of the considerations that are relevant to a surgical oncology population, of providers rather, and just sort of cool to talk about some of the topics. So we're not going to do an exhaustive conversation of all of the trials in colorectal cancer. First of all, sadly, fewer positive. Second of all, a lot of the differences are really nuanced. And third of all, I think a lot of this is beyond the scope of the conversation. A few comments. Next generation sequencing is critical in advanced colorectal cancer. There is no situation in which next generation sequencing is not necessary and may not change practice, change treatments for patients. So in all situations, critically important to have high quality tissue, core biopsies, not FNAs, metastatic site biopsies. Importantly, when you're seeing a patient who presents with metastatic disease, there is no reason, if you see a colon mass on CT and liver metastases, to subject a patient to a colonoscopy. When possible, percutaneous biopsies, which are safer, higher quality, get better tissue, and are lower risk, are preferred. We should not be taking patients to colonoscopy when they have liver mets or lung mets. In all cases, a fluoropyrimidine combination, either Capox or FOLFOX or its derivatives, are going to be the mainstay of treatment. And so as a consequence, DPD testing to look for toxicity from 5FU should also be considered. The standard first approach in colorectal cancer that is advanced, that is metastatic, should be FOLFOX or Capox as an alternative, the oral regimen. FOLFIRI is equally reasonable, and there's lots of discussion about what you should do first. They're probably relatively interchangeable. And what's different between them is the toxicity profile. And then we have the regimen FOLFOXIRI, which is FOLFOX plus a dose of irinotecan. It's an escalated regimen. It is more effective and more toxic, and we can talk about some of those considerations, and in particular, where they stand on oligometastatic and resectable disease. Just to mention some of the clinical trials, this is FOLFOXIRI versus FOLFOX. This is the STEAM trial. All these patients also receive bevacizumab. You can see that FOLFOXIRI has a progression-free survival over FOLFOX. There's also more objective responses. There's also more toxicity, and yet overall survival is not substantially changed. So more chemotherapy up front may not change the outcome in the long run, but short-term outcomes are improved. Follow-up data has added some nuance to this discussion, but there is not a major benefit to more is better. Similar finding in the TRIBE study. This is FOLFOXIRI versus FOLFIRI. This is a simpler design. The prior one would alternating cycles and so forth. Here we saw that there was a bit more of a benefit to FOLFOXIRI versus FOLFIRI. That was a little bit less for patients with adjuvant therapy, which kind of makes sense. They'd already been exposed to oxaliplatin in the adjuvant setting. And there was some benefit in particular for right-sided cancers. Essentially, right-sided cancers did worse, and FOLFOXIRI mitigated risk better. Again, chemotherapy mitigates risk. So where I think about this and this discussion of doublets versus triplets in colorectal cancer is that we need next-generation sequencing. We should biopsy the metastatic site. We can see that FOLFOXIRI has a place. We talked about before, symptomatic diseases may do better with triplets in rectal cancer. We could probably say a similar thing in colon cancer. And we can see that the right-sided, more aggressive cancers tend to do better with FOLFOXIRI. We also have data showing that BRAF mutated cancers do better with first-line FOLFOXIRI. we have to think about the toxicity profile when we're offering these things to patients. For a patient who's relatively polysymptomatic or asymptomatic disease, it's not clear to me if more is better. And for patients with poor performance status, clearly more is not better. We also have to think about the role of fatty liver injury. Triplet regimens are more likely to result in fatty liver injury, which is relevant for the discussion of oligometastatic disease and future paths in colorectal cancer. Monoclonal antibody therapy against EGFR. Remember back to our cartoon of the MAP kinase pathway. We have EGFR, we have RAS, RAF, ERK, et cetera, et cetera. So we have 2 drugs approved for EGFR therapy. One of them is panitumumab, the other is cetuximab. For all intents and purposes, they're interchangeable, but there's an important difference. Panitumumab is fully humanized, and you're less likely to have anaphylaxis to it than cetuximab. Otherwise, they're kind of interchangeable. They have a unique toxicity profile of rash, hypomagnesemia, acne. They're kind of a little bit annoying. Patients don't always feel great on them. We have evidence for FOLFOX plus or minus an EGFR inhibitor. There's a PFS benefit. We have evidence for FOLFIRI plus or minus an EGFR inhibitor. There's a PFS benefit. So these drugs help for RAS-RAF wild-type cancers, especially left-sided disease. Importantly, a lot of effort has been done to look at oligometastatic disease and how we can maximize preoperative benefit prior to any surgical resection on the liver. And what we saw unexpectedly was that EGFR inhibitors make things worse. So you would expect for patients with large, bulky metastatic disease that cytoreduction is always better. Cytoreduction didn't translate to overall survival. And in fact, the patients who received cetuximab in the neoadjuvant setting had worse outcomes than those who did not. This was a clinical trial of FOLFOX or FOLFIRI, sort of accounting for both options. Again, I don't think there's any reason to think of FOLFIRI in the neoadjuvant adjuvant setting, but that's what is done sometimes, and it was studied here, plus or minus cetuximab in patients who have KRAS wild-type cancers and BRAF wild-type cancers, where cetuximab is an effective drug in the advanced disease setting. And we see a substantial worsening of overall survival. So this is not a combination that should be offered to patients neoadjuvantly with liver metastases. EGFR really is off the table. I think it's an important question to think about in other settings, whether it's going to be true in lung metastases or some other thing we're going to do surgery. It's actually unknown, but I would say I interpret these data as be very cautious with EGFR inhibitors. So to summarize the EGFR monoclonal antibody therapy, they do add benefit in RAS-RAF wild-type cancers. That benefit is perhaps more significant in FOLFIRI than FOLFOX, though that's comparison between trials, not between regimens. The efficacy is very limited or absent in right-sided cancers, and there's a variety of trials which have looked at that. The toxicity of these drugs is significant, or acneiform rash. They can have ocular toxicity, electrolyte wasting, and then the allergen cetuximab is not nothing. I think that these generally should be delayed until second-line therapy to mitigate the length of exposure and toxicity. And importantly, I would not offer these for patients undergoing liver resection. And when possible, I would avoid them in any patient undergoing surgery because of that, the new EPOC study. There's a few other subtypes we're going to talk about very briefly before we get to some questions. So Beacon was a clinical trial looking at BRAF-mutated cancers, once again, a MAP kinase member. Those looked at cetuximab again, plus or minus BRAF-directed inhibitor, and corafenib with a MEK inhibitor, binimetinib. And there was a major response. As you can see, we took BRAF, which is really the worst player in colorectal cancer, and you see improvement in survival, and you see major responses in your waterfall plot. This is a great regimen. If you need to use this to get patients to the operating room, chances are they're not actually operable, and you are thinking about cetuximab again. But it's important to know when you get that BRAF news, which we see as bad news, there are options and good options, and hopefully we'll have more options soon. Just as common as BRAF is HER2, and this has been really hot lately. So the Mountaineer study looked at tucatinib and trastuzumab. Tucatinib is a selective RAS inhibitor with a HER2 RAS inhibitor with trastuzumab, famous trastuzumab HER2 inhibitor, monoclonal antibody therapy. And what we saw was a major improvement. We saw complete responses in this population and prolonged responses, very well tolerated, maybe some diarrhea and transaminase elevations, but for the most part, quite good. Critically important, tucatinib is not going to work if you have a RAS mutation. That has to be tested for. Again, emphasizing the importance of next generation sequencing in all patients with advanced disease. And then with the Destiny CRC study, these names, Mountaineer, EPOC, and Destiny, I have, complex about trial names. So Destiny CRC, these patients, I guess, were destined to receive trastuzumab deruxtecan. They benefited substantially Importantly, patients were included in this trial with prior to tucatinib. The most important adverse event was pulmonary toxicity, which is not minor. This can be quite significant. And the benefit really was limited to HER2 3+ disease, highly amplified cancers, not 2+ disease. To summarize HER2 amplified cancers, for HER2 amplified cancers that are RAS wild type, tucatinib with trastuzumab and trastuzumab deruxtecan are both considerations. If there's a RAS mutation, tucatinib is not going to work. It's not a consideration. And there is some data that you can do trastuzumab deruxtecan after tucatinib, but that was not prospectively assessed, but it's a consideration. Finally, we can talk about immune therapy in colorectal cancer. Everyone wants immune therapy to work. I want immune therapy to work. We all want immune therapy to work. Immune therapy so far in colorectal cancer has not worked in mature clinical trials, except in rare cases. So mismatch repair deficient disease is present in about 3% of advanced cancers. And these are the ones that respond to checkpoint blockade. If you think back to that earlier gel we showed where there was a neoantigen, that's sort of a almost cartoon-like manifestation of this problem that neoantigens create. But those are things that can be targeted by the immune system. So that neoantigen is not insignificant. What we see in prospective studies of, for example, ipilimumab with nivolumab for mismatch repair deficient colorectal cancer is that there are major responses in all subtypes of mismatch repair deficient cancers. They do really, really well. We have now multiple mature clinical trials showing that for MMRD cancers, this is a highly active regimen, and we have emerging data in MMRD cancers in the neoadjuvant setting in colon cancer. So it's an important consideration, again, why no one should ever be assessed for colorectal cancer without MMR testing. The big splash by Andrew Sursic, now a year and a half ago at ASCO, was the dostarlimab data looking at patients with MMRD rectal cancer and essentially 100% response, and in follow-up, virtually 100% response for checkpoint blockade with a PD-1 inhibitor alone, dostarlimab, for locally advanced rectal cancer. This is now open, enrolling a prospective trial across the United States. When possible, patients should be enrolled in that clinical trial to best understand these patients. If that trial is not available, I think this does represent a new standard of care. Patients should not be taken to the operating room with an MMRD rectal cancer. So we're talking about a new checkpoint blockade because we want immune therapy to work. I'm going to go back a couple slides in case we missed some important points. So I talked briefly, this is the role we now, about the role of mismatch repair deficient rectal cancer. It's quite uncommon. Responses are nearly universal with single agent PD-1 inhibitors, dostarlimab. I think patients should be enrolled in this clinical trial when possible, led by Andrea Sursic. But if it's not possible, I think this does represent a standard of care with non-operative management and close monitoring with rescue with chemoradiotherapy and surgery is appropriate. For MSS cancers, this is 97% of advanced colorectal cancer. FOLFOX and bevacizumab plus or minus the checkpoint blockade nivolumab. There is no benefit. A lot of effort has been done to find a subset of patients who benefited from this. They didn't. Okay, we can move on from this conversation. There's just not enough juice there. We have a new drug on the scene, and I've worked on this drug. This was Andrew Bolt's presentation at GI ESMO, looking at a new agent called botensilimab. It is a multifunctional CTLA-4 inhibitor plus a PD-1 inhibitor, balstilimab. And what we saw was major responses in patients with very, very refractory colorectal cancer. Those responses were largely limited to those without active liver metastases. Some subset of individuals with liver metastases had stable disease, but objective responses were not seen. And if we look at this survival curve, we can see that the patients with active liver metastases in the bottom, they really don't get a lot of benefit. For those with no liver metastases or resected liver metastases, they did quite well. And this, I think, will be, if these data hold true in phase 3 stop trials, this is going to be a practice-changing trial, and this is going to inform our decisions around surgery on the liver. This is a very important consideration as we enter a new era in checkpoint blockade. So, being thoughtful about time, the learning points are this. All patients need MMR testing at diagnosis, as well as a CEA and a CT of the torso. Early stage cancer should receive adjuvant therapy as appropriate based on the risk profile, 3 months versus 6 months, 5FU versus FOLFOX or CAPOX. Rectal cancer management is changing rapidly, and I think this is a critical time where we need to get all patients into multidisciplinary care whenever possible. I would be cautious about one-size-fits-all decision-making in rectal cancer. Just because we have a paradigm in the Produce 23 trial, we see good data for an overall population, that doesn't mean that all patients fit that population. Just because we have a paradigm in the Prospect trial where some individuals can avoid radiation, that does not mean that all individuals can avoid radiation with high-risk disease. We have to really stick to the data. We have to be careful when we think about non-operative management, what we are promising prospectively, so that patients have realistic expectations around a total neoadjuvant approach with chemoradiotherapy followed by chemotherapy, and then non-operative management versus surgery. Any patient who's being considered for an OPRA approach like that, I think should be considered for the Janus trial to investigate the role of escalation to irinotecan. If that's not available and the OPRA approach is reasonable outside of a clinical trial, I would not escalate to FOLFIRINOX. We talked about next generation sequencing. It is really critical that we know these things, that we know whether we can give EGFR inhibitors, BRAF inhibitors, and HER2 directed therapy. But critically, there is a signal towards harm of EGFR inhibitors in the neoadjuvant setting. So anytime surgery is a consideration, I don't think that these drugs should be used unless absolutely critical. If you need a response to get a patient to the operating room, then FOLFOXIRI or FOLFIRINOX is probably the preferred approach, as opposed to trying to do FOLFOX plus an EGFR inhibitor, for example. And if you need FOLFOXIRI plus an EGFR inhibitor, I think realistically, you can try it. It's hard to know if your patient's really operable in that setting, if you're achieving much. We just don't know yet. And finally, immune therapy is critically important in mismatch repair deficient cancers. I think immune therapy is emerging in microsatellite stable cancers. We have compelling data from the multifunctional CTLA-4 inhibitor botensilimab, which is not yet FDA approved, which is open in clinical trial. But there's an important lesson there that organ is a biomarker, that the absence of liver metastases may affect outcomes for patients. And there may be a time where it's increasingly important that we address metastatic disease in the liver to open doors for patients to go on clinical trials of these agents and hopefully open doors for accepted regimens that are FDA approved. And that's really the goal of those trials. There's lots of other cool stuff coming. We have 3 advanced disease agents that are uncommonly used. We have Lonsurf with bevacizumab. We have regorafenib. We have the new drug fruquintinib. None of them are terribly relevant in the surgical consideration. Those are all for patients who have had treatment and failure of 5-FU, oxaliplatin, irinotecan, bevacizumab, and EGFR inhibitor as appropriate. So that's a special population. Those are important drugs, a little bit less relevant for this conversation. So hopefully we didn't lose too much when I was offline. I'm happy to take any questions.
Awesome. Thank you very much, Dr. Schlechter. That was super awesome, comprehensive crash course for all the surgical fellows out there. I only have one question for you, and it's sort of a soft skills type of question. Mm-hmm. What, we talk about this among the fellows a lot, and it's a very hot topic right now. In terms of, organ preservation approach after total neoadjuvant therapy, what is your take on who should be having that conversation with patients? When should we be having that conversation with patients? Do you think that it's better had by the surgeon, by the oncologist? Do you think we need to see how patients respond before, we deem that they're a candidate before we even bring it up? Or is it something that patients are walking into the office now with, information about organ preservation approach? Of course, I'm talking about rectal cancer, in hand. And if you don't mention it at the outset, then they're going to think you're like missing some information.
Yeah, that's actually a great question, a hard one. I think there's a lot of considerations. So first of all, this is a situation where we have to be on message, where we as a medical oncology, surgical oncology, and radiation oncology community, and as physicians providing care for patients, we have to have the conversation together as providers and then with the patient. Who has that conversation, I think, is a hard one. It probably depends on the individuals involved. There's no situation where we shouldn't discuss it, but it's not something we should promise for everyone, and we have to be honest about pitfalls. So for patients with a gigantic symptomatic cancer, where you're like questioning whether you have to divert them to get started, I don't know that a chemoradiotherapy first approach, which has the best chance of achieving non-operative management, is in the best interest of the patient. It may be over-promising and under-delivering curative intent therapy. And so that's a situation where we could say you may have heard about this, but that's not in your best interest. For the patient who's got a very high low-risk tumor where they're going to have a high-quality LAR, the lowest possible risk of LAR syndrome. And in fact, their quality of life may be better with a chemotherapy only approach a la Prospect. Again, we can mention it and we should discuss it. We should have the conversation with patients, but it seems pretty clear that a chemotherapy only approach for a T3N1 or T2N1 of a high rectal cancer, I'm not sure that there's a lot of benefit for adding that chemoradiotherapy for a 78% chance that the patient's going to have the LAR anyway, and then they're going to have poor function. For the patient who says to me, I'd rather die than have an ostomy, I actually don't think non-operative management is the way to go. And here's why. Again, non-operative management is not a promise, it's an opportunity. And for a patient who could undergo a sphincter-sparing surgery, who then does long-course chemotherapy, and then regrowth, which is the most common scenario, they're more likely to end up with poor function or a sphincter. And so for a patient who has a good chance of a good LAR right up front, I actually give them the advice that they should do a conventional, chemoradiotherapy LAR or FOLFOX approach, et cetera, or use the Oprah approach of chemotherapy and chemotherapy, move right to surgery. And I think we're entitled to give patients our advice. And I will say to patients, these are these options. I'll draw them out in the paper on the bed or on the window with a dry erase marker, whichever I've got. And I'll say, for you, I recommend this for these reasons, but all of these things are reasonable considerations. This is what you gain with this. This is what you gain with that. What I don't do is, again, I don't go off the rails. If somebody's got a really bad locally advanced cancer and you start with FOLFIRINOX and then they have a nice response, I'm not going to invent the fact that they had a low risk cancer and then start treating them like a Prospect patient. So that's my personal approach. I don't know who should do the messaging. I think it's best when we do it together. Whenever humanly possible, we should all be in the room together with the patient.
Awesome. Well, thank you so much for joining us tonight, Dr. Schlechter. We really appreciate it. That was fantastic. And everybody out there, thank you for tuning in, and please check us out on crsvirtualed.org. You can look into information about our upcoming talks every Sunday night at 7 p.m.